physician saw, he asked for HRCT products. So when HRCT was done, the CT examination of the chest also included part of the upper abdomen. So in the upper abdomen, the person who reported, our radiologist noted that there are some dilated vessels seen, but could not comment what they are because it was done only as a test CT. So then we said we will do a proper CT abdomen. This is what was seen on CT abdomen. You can see the liver size is on the smaller side, small liver. IBC is big, and if you look at the portal vein is small. Portal vein in an adult should be somewhere near 8 mm or 10 mm, whereas in him it was measured only 5 mm. It is small. And as we come to the lower portion of the abdomen, we saw something unusual. These are all bowel loops. Whereas these rounded structures, what are filled on the right side, which are almost like bowel loops, they are not bowel loops, they are enlarged veins. And this set of enlarged veins, what you can see here, it is coming from the region of superior mesenteric vein. And if you see the IBC, just next to the IBC, you can see the dilated vein here, and ultimately it has joined the IBC. So after seeing this CT, Dr. Pushpinder drew a schematic diagram here, how it is. You can see the portal vein, superior mesenteric vein, splenic vein, and this is a very long tortuous vein which is coming and joining the IBC. What is happening in this patient? There is a congenitally existing extra vein in him which is connected between the superior mesenteric to the IBC. Majority of the blood from portal circulation, instead of going through the liver and getting filtered in the liver, it is directly coming to the systemic circulation. What are the disadvantages in this? One is liver is not getting adequately perfused. Secondly, several catecholamines and other products in the portal circulation is directly shunted to the systemic circulation. These catecholamines can have bad effect on the pulmonary arteries. They have vasoconstrictive effect. He had peripheral vascular constriction in the pulmonary bed because of which patient had severe pulmonary arterial hypertension. So this was his problem. After seeing this patient in the next few years, what we have seen is different patients of this problem have presented in variable clinical manifestation. One child who presented with autism, we found he had a shunt like this, and another patient who underwent liver transplantation. Following liver transplantation, he was not recovering. He was not coming out of oxygen. We realized that one large vein like this we have mistaken for a bowel loop, and it was totally missing 4 CT scans. 4 CT scans. And better late than never, we identified this vein, we blocked the vein, patient recovered. So for this patient also, the options available, one is surgical ligation, tips, radiological closure of the shunt, and temporary balloon occlusion of the shunt. So this was actually prepared like a audience poll voting. Whoever thinks surgical ligation of the shunt is right, please raise your hands. Choice A. Okay, I see 2 hands. Who thinks that we should do a tips for this patient, please raise your hands. Nobody, because tips is already there. The equivalent of tips is already there. This also gives us an idea. If you keep on doing many tips, and if you follow them for several years, like 20 years or 30 years, that patient can have a problem like this. So that you have to be aware. But one thing to say that this shunt is much bigger than the tip shunt. How many people think radiological closure of the shunt is the one to be done? Okay, you see 15 hands. How many people think temporary balloon occlusion of the shunt and see what happens to the patient? Okay, I see maximum number of hands. So this is what we also did. So we cannulated from the internal jugular vein. This is the inferior vena cava, and inferior vena cava is continuing lower down. Here we have entered into the collateral. This collateral is as big as inferior vena cava in some cases. We kept a balloon inflated, and when we saw the literature, there are only case reports for this particular abnormality, what is labeled as aberrant malformation. This is called aberrant malformation, and it's important to know when we block this, what happens to the portal pressure. If the portal pressure goes suddenly high and this liver is not able to cope with the increased blood flow into the liver, you may develop either immediate or chronic problems. So when we inflated this balloon, the pressure went up and we thought we'll keep this balloon inflated for 24 hours. Then we reassess what happens, because sometimes when we block the shunt, there can be some compensatory mechanism. Though the pressure is high, after a few hours the pressure may come down. So we inflated this balloon and we sent him to ICU. We thought next day we'll bring him back. Next day, patient said he is feeling better because he was able to tell he was continuously on oxygen support. He said my oxygen support is not required much. I am feeling better. Then we realized that this particular balloon, what we intentionally got inflated, was already deflated because one of the team members in the ICU wanted to give some intravenous injection. They have actually injected into the balloon pore of this balloon. So if you put a syringe and remove, and if you are not careful, the balloon, whatever is inside the balloon can come. So same thing happened. So if balloon got deflated or more inflated, we don't know when it happened. And so we looked it back and we did an ultrasound. We saw that this shunt was not having any flow. This entire shunt had spontaneous thrombosis. It was totally unintentional. So below basically what has happened, it has created some internal injury. This internal injury has changed the balance of varicose clot. Varicose clot contains endothelial injury, that's what we have created. Space is created. So two things we have changed. So that has resulted in thrombosis. But this particular complication has helped the patient in his treatment. We are wondering how to block this shunt later, whereas God has healed and he has thrombosed this particular shunt. How is the follow-up? There was marked improvement. There was no, he was able to walk very well. And his clubbing and sinus both disappeared. With grade 4 clubbing, which I was thinking that it will always remain lifelong, but it has completely disappeared in him. And we also checked the volume of the liver. This was before the procedure, where you can see portal vein is small, portal vein is big now. Liver volume, when we measured, it has increased by, I think, about 60%. This is the region of his lower abdomen, where we saw large vein sitting earlier. Now it is no more seen. We don't see any trace of that. So, the benefit of medical students, this is how it is spelled, abdominal malformation. And we were not aware of this condition a few years ago. Now we have seen about 7 patients. And 4 patients we have treated. 4 patients we have treated. And yesterday when I was talking to Dr. Pushpinਦਰ, his other colleague from Bangalore called him and he said he found a different pattern of abdominal malformation. He was asking what where to treat it. So if you see this diagram, type 2 is the one where there is some portal vein existing, dividing to right branch, left branch, but entire this portal system will be small in size. Whereas yesterday our friend Dr. Vaishak called from Bangalore and said, portal vein or splenic vein, superior vein, all are joining to IVC. They are not entering the liver at all. This particular pattern I have not seen before, but I only heard yesterday. So these are all various types of hepatic interventions. Now I will show one example of biliary intervention. Nothing to tell is biliary intervention has advanced because of advancement in the technology, mainly from endoscopy side as well as interventional side. We have 3 types of biliary drainage. External is a type of drainage where we drain the bile through a tube outside into a bag. External internal drain, which is usually done for sick patients, where we pass a long tube through percutaneous access through the liver. It enters the biliary system across the block, and tip of this tube is inside the duodenum or jejunum. What is the advantage of external internal drain? Because we can block this tube from outside. This long tube has got several side holes. Bile enters through these side holes, and we have the advantage of sending this bile into the patient body itself. We don't have to drain this bile outside and later give to the patient. Finally, when the patient has to go home, she should not be having any, he or she should not be having any tubes hanging outside. It's very cumbersome, very difficult to manage those tubes. So we need to have drainage only inside. Remember, these biliary drainages are done only for the patients who cannot have a definitive surgical treatment for biliary blockage, for one. Patients who cannot get this intervention directly done by endoscopists for some problem. Now, the difficulties which endoscopists will face, probably Dr. Bhargava will address later sometime, and in our practice, all patients will go to endoscopy first. Let's say there is some tumor in the duodenum, or there is a difficult annulation of the terminal cavity, or let us say the biliary obstruction is very high, 3 ducts are blocked. In such situations, we take over and we perform the procedure percutaneously. As in this patient who had rapidly increasing jaundice for a period of 1 month, you can see there is biliary dilation in the right lobe, biliary dilation in the left lobe, and there is a mass in the gallbladder. This is MR cholangiogram. This MR cholangiogram is very useful because non-invasively we are telling the status of the biliary without injecting any contrast. Because whenever we inject contrast into the blocked system, whether it's done endoscopically or percutaneously, we are increasing the chance of infection to the patient. Because by the stasis, so if we inject some contrast there can be potential risk of complication. So if 3 ducts are blocked, we can open all of them. If all these patients have to be under antibiotic cover, we need to make sure that the bleeding parameters are normal. If the patient has got bleeding parameters, patient can bleed at the time of procedure. But there should not be any ascites. If there is ascites, what happens is the bone what will become the liver surface, towards liver capsule. Liver capsule is very vascular. It can keep on bleeding, especially if we are not successful with first puncture. Whereas if we are taking the first puncture tract itself, what will happen is whatever the bleeding happens, it can be seen by the tube. So this is how we perform this procedure. We use an ultrasound probe and under ultrasound guidance, we access the biliary system. You can see this red line is the expected track to reach the biliary system. And once we puncture the biliary system, we can see the T and Y coming through the needle. You aspirate and send it for culture. Then inject very small amount of contrast. Contrast should be very small because if you inject too much of contrast, what will happen is the pressure inside the biliary system will be more. And organism, if they are contained in the biliary system, will be sending it to the blood. And patient can have a sudden bacteremia or septicemia, and patient will have bad cysts, and that will become very difficult to control later. Then we pass wires and pass the tube. And this is, here you can see a tube which is coming through the liver, through the biliary system. It has got multiple side walls. This tube has gone up to the duodenum, and this is an example of external internal biliary tract. Story is not over because we have put the tube to only one tube, one outside the biliary system. This is the second biliary system which is constructed. We have placed another external drain. This is the picture of the tube. I see from our industry colleagues who company has brought some biliary external internal drain tubes which are displayed outside. You can see so many side rolls are there, and when we get saline, you can see it's all coming to the side rolls. Following this, we have to check the vital parameters of the patient, check the biliary drainage, and also watch for abdominal blood, whether there is increased blood of the abdomen. And this is how it looks on day 3. We have accessed the third block duct. We have stented all the 3 ducts. We have placed the ducts side by side. Following this, what we do is we keep a temporary external drain. Temporary external drain so that there is no bleeding or not bleeding blood clots block this fence. And this is how ugly is the appearance with 3 drainage tubes outside. And if you send any patient like this home, it's a crime. Better than that is not do anything. So this is on day 5. You can see multiple stents here. This is an example of converting into internal drain. So initially we started with external internal drain. We have finally converted into internal drain. And we have removed all the tubes after checking that the internal drains are working well. And this is the plaster. This is just to highlight that there are several ways of treating patients, and sometimes there can be a complication in one particular subspecialty or specialty. For that, another subspecialty person may have a very simple solution. It can be a liver transplantation, but a very major surgery, but the patient's hepatic arteries are very blocked. For us, it may be 20 minutes job or 30 minutes job to pass a catheter there to remove a small blood clot, and patient is alright. A major surgery is provided. Similarly, let us say we have done an arteriotomy or let us say angiogram. Little later, patient pulse is not profitable. That time we need the help of surgeon. By surgical way, he may have to remove the blood clot. When we do 200 angiograms like this, one patient can have a problem like this. So we are mutually dependent each other. It is not like in TV serial house where people do everything. We will start from clinical examination, angiogram, and I saw a couple of weeks ago he was doing transfusional liver biopsy, which Dr. Pushpinਦਰ Singh is going to tell. And so, whereas in real life, we are all mutually dependent each other. And patient is the best beneficiary in this game. I thank you for your attention.
Thank you for the wonderful lecture. What is your experience being with Vellore syndrome and the tips and all these procedures?
Yes, sir. So, Vellore syndrome we have been managing for several decades actually, and we started doing aggressive endovascular management maybe about 15 years ago. And so far we have treated about 300 plus patients endovascularly, and we have a team on. All these patients are first coming to hepatology department or pediatric department, and very rarely they may go to surgery department. And we have meetings every week. We have interdepartmental meetings, and during the interdepartmental meetings we discuss these cases and we see who will be the beneficiary. Our workup is after clinical examination. Imaging wise, we do ultrasound meeting, ultrasound and doctor. If we cannot sort out on ultrasound doctor, then we do CT scan. If the patient's creatinine is okay. And patients who are aggressively symptomatic, we go out of the way to treat. Whereas if the patient's symptoms are borderline, mild ascites, can be managed by medical management. If hepatic veins and IVC can be opened up, we go. That's physiological restoration. Whereas doing tips for that patient where let us say hepatic veins cannot be opened, but patient is mildly clinically symptomatic, is a relative indication. Patient grossly symptomatic, hepatic veins cannot be opened up, IVC is present, tips is an absolute indication. Now, by doing tips, what happens is we are decongesting the liver. If the patient is significantly symptomatic, he will know that there is an obvious difference in his lifestyle. Whereas the patient is not clinically significantly symptomatic, and if we perform tips, he may not appreciate much by we will perform tips. So this we have kept as a relative indication. We are not very aggressive. And out of these patients, success rate is about 95%. The immediate success, technical success about 95%. And clinical success may be about 80%, maybe about 10% less. And once these patients undergo intervention, all these patients are put on warfarin, and INR is kept between 2 to 3, and they have followed up. Either they are asked to come to our place directly, or the person who is referred will be monitoring in their respective, the clinician will be monitoring in their respective places. And maybe once in a year or once in 2 years, patient will come. And complication wise, it's important for me to tell about complication also. Mortality is expected to be about 1% in all this patient, and we have lost one patient out of this 300. That happened in early 2000. The mistake was every time we lose a patient, we have mortality meeting, and we find out, we audit the case and see why we have gone wrong. This particular patient, what had happened is we have kept the patient in regular ward. This happened in maybe early 2002 also. After that, we made a point that All these patients are kept in ICU. So that if the patient deteriorates, we will know immediately. So that is number one. And number two, if the patient is a child, procedure is completely performed under anesthesia. And if you are doing DIPS procedure, patient is under anesthesia. And so this is about overall bacterial management in our place.
What are the percentage of bacteria which landed into liver transplant?
Liver transplantation in India may be low, sir, I do not know. And in our center, most of these patients are managed by India Hospital. Out of these 300 patients, at least 15-20 patients would have been referred for liver transplantation to our center. But none of them finally underwent liver transplantation. But what I understand is in UK, where they are doing aggressive bacterial management, liver transplantation is their ultimate final treatment. They keep it delayed. Till when we can manage, let us say by physiological restoration, we stent it and see how it works. You will get 2 or 3 years of quality life. Little later the stent may fail, then we can consider DIPS. That may give another life for another 5 years or 10 years. If that also does not work, then we can be taken for, patient can be taken for liver transplantation. Because liver transplantation is not end of the problem. It may be beginning of next series of complications. Because when we do liver transplantation, there are several complications involved and lot of logistical support is required. So it is kept as final treatment. Another reason why liver transplantation may be delayed, these patients may have abnormal coagulation factors. The liver transplantation success rate also may be relatively less in this group of patients compared to the regular patient for liver transplantation.
That brings us to the question, what is the ecological profile of such patients?
Yes. So now these patients have abnormal coagulation in about 20-25%. But in other 75%, we have not identified any abnormal coagulation. And irrespective of patient's problem, they are all put on anticoagulation. And the type of bacteria what we are seeing, they are in advanced cases. We are not seeing them when the hepatic venous thrombosis happens. We are seeing them little later, where thrombosis has resolved, but it has kept a residue in terms of a segmental pollution or in terms of a membrane. So we are not seeing them much in their acute phase. Either they are not clinically reporting or they may be managed with the anticoagulation and headache. Most of these patients are late cases. Yes, sir.
Polycythemia vera and the other malproliferative diseases and also clinic sometimes present with blood chain.
Yes.
So in those subset of patients, like what is your intervention experience or are they purely managed medically?
I think if the patient comes with an acute problem of thrombosis, you are telling the patient coming with a thrombosis or late present, I think those may be managed medically. And we have done only a couple of cases of thrombolysis for acute hepatic venous thrombosis. The thrombolysis does not work all that well in hepatic vein compared to, let us say, a femoral artery. Femoral artery thrombosis is there, or let us say iliac vein thrombosis is there. We remove the thrombus and thrombolysis, it works very well. Whereas in the hepatic vein does not work well. The reason is hepatic vein has got slow flow. Its velocity is very less. Secondly, there are so many tributaries. The way we approach is from center to periphery. It is against the direction of flow. Whereas in an artery, when we do thrombolysis, it is along the direction of flow. So whatever recanalization happens, that recanalization will carry some amount of urokinase or TPA along with that. Whereas here, it is opposite to the direction of the flow. So it does not technically work very well. I hope I have partially answered your question, though I am not do it completely. So in such situation, what you give intravenously, TPA or any other thrombolytic agent may be as effective as what we do invasively. So we need to know when we need to do invasive therapy and when there is no additional benefit to the patient. Whenever we find there is no much of additional help, we should not be subjecting the patient for invasive treatment. Mainly because of the cost, number one, and complication rate is high.
Sir, as an oncologist, we also see certain accuracy in which the lesion size, primary lesion sizes still available to taste. However, there is a total venous thrombosis.
Yes.
That becomes a big impact. How to address that?
Yes.
So, what are your opinions about handling CVD?
This is a very important question. Patient has got hepatocellular carcinoma, not suitable for surgery. He has got total venous thrombosis. Can we do TACE? When we do TACE, we are blocking the hepatic artery. Portal vein is already blocked. So if you totally devascularize the liver, what will happen? So if main portal vein is involved, there is no question of TACE. Whereas if it is a branch of the portal vein, let us say segmental branch, then it's not a big deal. We can go ahead with TACE. Whereas if it is a right branch or left branch of portal vein which is involved, then we can do TACE with under-embolization. In the regular case, what we do is we inject hemoembolic agents, and finally we block of the hepatic artery, so that the subsequently entering fresh blood does not wash away the chemotherapy agent. Whereas in these patients, we can do partial TACE. One thing to remember is if the TACE is not done properly, it may not serve much purpose. So these all come under related indication. The clear-cut cases what we are taking are localized HCC, preferably in one lobe, not suitable for surgery, patent portal. Patent portal is partially thrombosed. Then we try not to do this.
Why thrombolysis through intervention is not
To the
so.
portal vein. Yeah. Portal vein thrombolysis we do if it is a regular thrombus.
For tumor thrombosis.
For tumor thrombosis we will not be able to do because tumor is already there in the portal vein. Whereas if it's we also had an interesting case of Bhattier who was waiting for DIPS procedure, and she had thrombosis of all hepatic veins, not referable, patent LVC, patent portal vein. 2 days before the scheduled time, she again came to the hospital and said, I have got severe pain of it. Then we saw the portal vein also has thrombosed. So in her whatever hypercoagulability she had has acted in the portal vein also. See, these patients can develop thrombosis in different locations. So in that patient, since it was not a tumor thrombosis, I am just mentioning this example of how we can do this. We took her on emergency basis to do DIPS. We did DIPS. We enter the portal vein. We suck the thrombus from the portal vein. After that, we place a stent. So you have what had happened by placing this stent. It has almost cured the Bhattier syndrome as well as portal venous thrombosis. Whereas if the portal venous thrombosis is due to a tumor, we cannot do the same thing.
What
Please go.
has been your experience with using preoperative embolization for the tumors? Some general surgeon has been operating preoperative embolization. How effective has it been? How willing are the surgeons?
Yes. I must say, sir, this is a very valid question. Preoperative embolization is very much established practice. Yes. Now, some tumors are definitely connected with preoperative embolization. These are the tumors. I'll give an example of juvenile nasopharyngeal angiofibroma, JNA, from which are usually seen by ENT surgeons. These are seen in young men. When I was in second year MBBS, my classmate, actually first year, when I was in first year MBBS, one of our classmates had mass in the nasopharyngeal area, and he underwent surgery by the ENT surgeon, the ENT professor operated on him. At that time, 20 of us donated blood. 20 of our classmates donated blood for him. And that much was the bleeding, expected bleeding from this tumor. Whereas today, because we have preoperative embolization, we can embolize this tumor and it becomes totally irrevascular. In our place, we have embolized nearly 150 or 180 juvenile nasopharyngeal angiofibroma, which takes about 45 minutes. And patient will be under anesthesia again. What we do is, let us say patient surgery is planned today. 7:30 will come to our room.